All right, thank you so much. Thank you everyone for being here. This is just phenomenal. I'm so excited about this panel today, and I can't wait to hear our speakers. And so with that, I am actually not going to have any words to say other than I'm so excited to see where this takes us. And my gig is workforce development. So if you want to hear what we're doing at UTHealth Houston about that, I'm in the education and literacy breakout. So with that, I'm going to turn it over to our friends from UT Austin, Dr. Jensen and Dr. Buntrock.
Good morning. I'm the Chief Technology Officer for Dell Medical School. That covers a range of things from data platform to building a new hospital. We talked a lot about data this morning already. What's really interesting about data is that's not my slide.
No, those slides were for my breakout.
That's all right. We'll get there.
Those slides were for my breakout. Sorry.
No worries. What's interesting about data is that it exists in two forms. And we've spent more time on the one form than the other over the last decade or two. The one form is data is useful operationally. It's what powers our operational systems that we use when we take care of people. And we've made progress, it's not perfect, on things like interoperability, EHRs, etc. The other side of it is how data exists for discovery, for innovation, for development. Turns out that the form on the left side is not particularly well suited for what you need to do on the right. And we've tried lots of things from data lakes, some call them data swamps, to data warehouses, which end up being straitjackets in terms of not being able to use the data the way you want to. So neither of those extremes are actually the right answer. We started this project called Unlock to solve that problem. It started about 10 months ago. And the objective was quite simple. It was make sure that the data that exists in that form, which is ready for operational use, can meaningfully be harvested and put together for innovation, research, and driving the frontier of healthcare science. So what did we try to do? Well, we wanted to design a data platform that was nimble in terms of what data it had, because there's lots of kinds. We talked about that. It's a forward-looking architecture because work keeps changing, so you can't actually tie it down to just one kind of data in one format. We really wanted to have a single platform for data management and analytics. And it had to be easy for research and education projects. Like, too many times we build technology for technology's sake. You build this data platform, it's great, it's locked down, it's secure. It's not actually easy to use. And it's not necessarily tied well into your IIB, research, grant, etc. processes. That's a bad place to be. You need to figure out what is the cohort that will drive your research. If you're a researcher, you're a PI, one of the hardest things to do is to just find out, is there even a data set that's relevant for the question I'm trying to answer? In most cases, figuring out whether there is a data set that does that is really hard. You need to build a platform that does a better job of that. We do need enterprise insight because it's not just the researchers. The enterprises also need to learn in terms of how we become better at what we do, so that's a dual purpose of learning, innovation, insight. It would be nice if we had all of the tools on board so you don't have to bring the data somewhere else. If you just have access to Python or your BI tools, be that Power BI or something else, you want to have an AI toolkit, all that would be nice if it lived in the same workspace and you didn't have to try to cobble all of that together yourself. It's all about easy. Strong security and compliance can't do the bad thing with data. And from an infrastructure and management perspective, if you have dozens or hundreds of projects that are using data for discovery, you can't manage all of that manually. So you need automation built into it. So this is what we came up with from an answer perspective. It's a diagram, but hey, this is a show and tell. I can't show you the live environment. It does exist. It runs. What I can show you is the visual of how we thought about the problem and solving it. So this is a two-sided picture. On the left side, there's a group of people, a small group of people, that manage our unified data fabric. It's not actually a technology. That is the amalgam of the data we have available, put together in a way where it's harvestable for discovery and research. At the same time, the right side of this is the ability to automatically create workspaces that have three things. It has the notion of a space you can work in as a team. It has a set of tools and capabilities ranging from a GitHub to manage your code, to basically having BI tools, AI toolkits, etc. And the third thing it has is an easy button that when you have approval to use a certain amount of data from the left, you ask someone to click the button and that data moves to the right in a secure and controlled fashion, and you can use it for what you're trying to do. Add to that you can bring your data on the right as well. So now you have your environment with shared data. You have your own data you can bring, and you can basically manage your team, and you don't have to stand up a server under your desk or couple together 7 different tools yourself. So happy to talk about that during the breaks. There was a lot of work and thought that went into this. It's a different way of managing the life cycle of nature of data that's aimed at innovation. Now, my colleague Jim will talk a little bit about some of the things we're doing with it. So Jim, your turn.
Thanks, Klaus. Good morning, everyone. I'm Jim Buntruck. I'm the Chief Data Officer at Dell Medical School. Recently joined 4 weeks ago. My prior role, I worked for Mayo Clinic for several decades, really supporting their data platform and AI initiatives, and including a number of informatics projects. So with that, just jumping in our keynote, Peter mentioned those silos of excellence. But I do want to note some of the strong partnerships. The centers of gravity here on the left-hand side, our Odin Institute, of course our TAC, our Texas Advanced Computing Center, as well as our Center for Computational Medicine led by Charlie Taylor and Machine Learning Lab with Adam Clivens. These are sort of intellectual melting pots to bring together diverse ideas to really break down those silos. On the right-hand side, in my first 4 weeks, I've got out and to meet a lot of different people, both on our main campus as well as within the Dell Medical School. Lots of interesting research going on, cross-disciplinary nature. We have a large program around pediatrics. Just to note here, the Pediatric Emergency Care and Readiness Project led by Kate Remick, which is one of our Dell Medical faculties. I also like to note some of our digital twin work, as well as our AI and their imaging and detection around cancer and diabetes, led by Charlie Taylor and Jack Verosco. But I'm going to take just a brief moment here around our neonatal early warning work and how that's really developed from a preliminary research into more of a computational effort. So this is work led by David Pedafar, who's a neurologist, to really, back 5 years ago, can we detect movement as a neurological vital sign in preterm infants? And can that movement be a signal to determine neonate progression in health and maturity, or their lack of, and require interventions? So this work was highly successful using just simple as pulse oximetry. They were able to create those models not just for week 1, but really as that neonate matures over several weeks in under ICU care. As we move on to the next slide here, really this flow of data, we accelerated this into a larger scale study. Right now we recruit 700 subjects. We're getting data real time, or we're getting data nightly around these different waveforms and efforts. And so the question is, can we validate that original model, but we can use other physiological detection to predict things like apnea, bradycardia, or hypoxia, but also look at care trends. Can we learn from this data in terms of do we need to increase oxygen? Can we look at earlier discharge from the NICU? Can we look at early sepsis? So this is great work that has scaled from early findings to the future. How we did that was really through an automated data pipeline. We're getting that data nightly. It goes over to our TAC for high computation. But this is just one example of many that the platform strategy that Klaus just mentions will start to create these paved pathways for our researchers to use and take advantage of, not only today, but as we anticipate, of course, our new hospital that we're building with MD Anderson. Thank you.
All right, thank you so much. Our next speaker is going to be Eric Martinez from the UT Medical School at the Rio Grande Valley.
Mic check. Everyone can hear me? All right. My name is Eric Martinez. I'm the Assistant Director for Business Intelligence and Enterprise Engineering at UTRGV School of Medicine / UTHealth RGV. My team is 3.5 people, and between the 3.5 of us, we manage the entire software development, AI engineering, data infrastructure, cloud infrastructure, software development, and we also help with reporting. So we do a lot of things, and I think that gives us a lot of power in that our ability to imagine ideas, we have the capability within just 3.5 people to develop the entire solution, top to bottom, full stack, without needing any other person, without having to submit a ticket to IT. We're able to manage that entire life cycle ourselves. And what I want to show you today is what our vision is for the future and some of the things that we have built. So the 3 big ideas that we care about is leveraging AI agents to assist with planning, execution, and management across our organization. So this is obviously a thing that when we talk about AI, we're always talking about the future. What I want to talk about today is what is possible today with today's technologies if you just put it into practice. Okay, and how do we do that in a way that is safe, HIPAA compliant, and et cetera? And that's what I'm going to share with you. So I have a lot of things to share, so I'm going to skip ahead to a lot of slides. But I want to just kind of frame the conversation here with, imagine that there's an AI agent that works like a vice president and thinks like a knowledge worker. One that turns organizational data into strategy, metrics into insight, and ideas into software. Okay, that was me just now. So what we did to enable this is we built a software platform that we call the Insight Portal. The Insight Portal helps with a lot of our data gaps within our organization, and so it has modules for strategic planning, faculty management, project management, clinic management, general knowledge, and it also integrates into the Microsoft 365 platform. Okay, this is what that looks like, and so this is without any AI. This is just, these are software that we build to help with various problems within the organization. So I'm just clicking through here a little bit. This shows you like our faculty management system, et cetera. Okay, so how productive could we be if the world's most powerful AI models were actually grounded in our organizational data? So what we built is an AI-powered data platform that we call Ada. And now what I'm going to show you is Ada on top of all of our organizational data. So here is how we manage strategic planning. So we have a software solution that enables leaders at our organization to manage our strategic plan for UTHealth as well as the School of Medicine. I'm going to skip through showing that so I can show you the AI. So here's our Ada platform, and we're going to ask a question about strategic planning. So do we have any strategic objectives related to our patient communication center? This is going to look at our strategic plans, our objectives, our themes, our goals, and be able to surface that information so that leaders can use AI to help develop new strategies, new objectives, new tactics that could benefit not just our academic enterprise, but as well as our clinic enterprise. So here we see that we have some objectives related to improving access to care by improving our patient communication center. Awesome. Okay, so that's one use case of the systems that we built. The next thing I want to show you is our advanced data analyst tool. So this is AI on top of our Azure Databricks data warehouse. One of the most common use cases that I hear about for AI is AI on top of your data platform. And that's exactly what you're going to see here. So here I'm asking a question to our advanced data analyst to show me the top departments in 2024 by number of encounters and the name of the department. So this is a HIPAA compliant software that we built that runs entirely on the user's computer. The only cloud dependency really is just access to a large language model that we do through Azure OpenAI. So it takes a little bit of time. PowerPoint does not let you edit videos, so you're actually watching it in real time as it's going through and running a bunch of computation under the hood. So just bear with me. I don't know how to fast forward on this, so we're going to watch it do some stuff. So it is first searching the data warehouse environment for relevant data. It is trying to find relevant databases, tables, and columns that could help answer my question. And now it is using Python, because that's what a lot of data analysts use. It's using Python to interact with that data environment doing computation, trying things, failing, trying again, so that it can generate the right queries that can help answer my question and ultimately give me the insight that I'm looking for. So this is a real-time video. This is on our real-life data, and so this shows us all of our clinical departments and the number of encounters that they had for 2024. Imagine the type of power that individuals could have in your organization if executives were able to wield this power themselves without having to submit a ticket to IT, without having to wait weeks and months for reports. Okay, so the next thing that I want to share with you is AI agent for population health. So in this example, we're asking the agent to show us our patients that are diabetic, that are missing A1C lab values so that we can help close these care gaps. This is synthetic data so that we're not leaking any PHI during this conversation, but this is a system that we're building and allows you to use natural language to basically see your patients on a map. This could be useful for planning facilities, this could be useful for closing care gaps, this could be useful for so many things, and I'm out of time. I have so many great things to share with you, but we have 4 posters upstairs where we are showing all of our AI agents, or some of our AI agents, and we're happy to pull out our computers and share them with you. Thank you.
Thank you, Eric. Yeah, and I would encourage you to seek him out during the rest of the meeting, but we got to move on. All right. Our next speaker is Dr. Peter McCaffrey from UTMB.
All right. Just want to say a shout out to Eric Martinez and his team, who are, of course, very vocal members of the collaborative. There's just a standard of excellence and craft of what they do that is really exemplary. I just want to shout that out. So, a couple of things. I think I want to start by saying the biggest innovative catalyst at UTMB is actually people and partnerships, not so much tech. And there's several people here. I see Jorge, I see Carlos, I see George, I see Kyle, I see Candace. I see Mark Schultz around here. I'll talk in a second about Mark. Each of these leaders at UTMB independently innovates, envisions, and executes. So just because I have A and I as letters in my title, I am neither the nexus nor the genesis of all the cool things that happen. So I'm here to kind of tell you about a lot of things other folks are doing that are transforming what we do. So to start, I want to recognize one of our teams, Mark Schultz and his team inside of UTMB, who produce a platform that we use for administrative chat, retrieval, and understanding of our data, but it goes much deeper than that. It's more than a platform. It manifests as chat, but beneath the hood, it's an entire tech stack of ontology labeling, graceful real-time updates of data, interrelationships between data models, mapping and remapping, testing, version control, flagging inaccuracies, flagging nullification of data, all to make it so that we can just ask questions of our enterprise and get answers immediately. And this is not a trivial thing. I think what this team has done to let us talk over our enterprise, whether it's grants, whether it's who's traveling where, whether it's how many patients have our views X, Y, and Z, is the product of tremendous innovation that team has done and has led on their own. I think they have a poster also. You should go check it out if you can. Secondly, I want to really recognize our IT leadership. So I saw George Gaddy around here and his folks who, this is one of many recent articles talking about our partnership with Microsoft, for example, and how this is innovative. But I want to emphasize that this is one example of a long and deep historical partnership that George has led that has elevated all of our capabilities. So these are things like having our data in an easy place, a liquid place to interact, whether it's in the cloud, in Fabric, moving Epic to Fabric, having early access to HIPAA-compliant LLM APIs, being able to freely build, design, test, iterate, and ideate with tech. This is something that department led early on to say we want to make this a safe space, iterate quickly, and through that we see all these byproducts bloom. I also want to recognize, of course, Jorge and Carlos both, Candace as well, who have led the massive campaign of ambient dictation and have done a great job. Another transformative pillar with independent vision and leadership. That's really the innovative asset of the enterprise, just to put that out there. So these are some internally led, internally developed things. I want to talk about some external things too. So there's some companies here we've partnered with, not just as a customer, but as an ideator, as someone in the long haul to build a better future together. I want to acknowledge one, which is Qualified Health. We thought it was important to give HIPAA and FERPA compliant chat access to all 14,000 of our employees early on, not just because it was a way to efficiently curtail the issue of HIPAA leakage, but it was a way to actually give people safe guardrails, understand how they use technology, profile the behaviors, segment the ladder of expertise, understand what makes a novice versus a good user, and embed agentic capabilities to the chat experience that drive people to successful use. It's more than just a blinking cursor in a chat bar. It is an experience on rails that ends with diffuse expertise. And this is the vision we really have for our whole workforce, upskilling everyone everywhere. We also have several specific agentic use cases, utilization management, gaps of care identification, and so forth. But really, this is in the hands of everyone at UTMB. They're encouraged to experiment, and they're encouraged to grow, and we see that happen. I also want to acknowledge another partner, Bunker Hill Health. I think they were sitting over here, but they're around. Nish, David, Ashley, if you get a chance to meet them. We work with them on a couple of campaigns, so screening, image-based screening of coronary artery calcification, for example, but not just detection, but also agentic navigation. It's one thing to find disease early. What do you do when you find disease early? Well, we're looking again further in this partnership across the vertical of solutions, not just finding, but navigating through things like CareBricks. Can things automatically adjudicate the appropriateness of a referral, do the outbound, do the email, do the phone call? Can I, as the clinician, take a role primarily of adjudication and not navigation? I think this is the future paradigm we want to get to. This is one example of this happening, and there will be many more. Lastly, I want to acknowledge an innovative company we work with that is actually spun out of radiologists at San Antonio. So an example of working across system and embracing others' innovations. So Cal Clark probably is here somewhere, radiologist San Antonio. We've worked with a company called Zaron Labs, spun out of that hospital system, to revolutionize how we understand the art of practice in radiologic diagnosis and how we drive improvement in that practice. So among the many things this does, one of them is every day it looks at all the reports and the images that have been created at UTMB. It understands inconsistencies between reports and images, and it will shuffle, mask, and redistribute images in a random subset to different radiologists to score, summarize this, and provide feedback. Here's how you did, here's what you missed, here's what others said you missed. The idea of this is that it's not just peer review, it's true peer learning, and it drives expertise through an agentic pedagogue, if you will, that can spend this time and this personal feedback to our radiologists to scale. And with that, thank you.
All right, thank you. Our next speaker is my colleague Xiaochen Zhang from UTHealth Houston.
Okay. So I'm Xiaochen. I'm from McWilliams School of Biomedical Informatics. So today I'm going to highlight a few development projects that transforming our healthcare application with AI. As Dr. Zerwas was mentioning, AI is no longer a buzzword. AI is now becoming a tool to allow us to augment the ability to deal with everyday work in healthcare. So I'm going to talk about a few applications related to how AI is allowing us streamline workflow, automate text processing, doing translation, building onboarding workflow, as well as like robotics. So one of the early projects we have developed here in collaboration with Center for Digital Health Innovation is this ID Fax project, stands for Intelligent Document for Fax Automation. So in the 20 months period since we deploy, still on deploying, we have already automated more than 300,000 faxes, roughly saving more than 8,000 hours of staff time. So yesterday I just calculated based on before and after time spent on the system, we save roughly 70% of average fax processing. Now there are 400 people using that on a daily basis. And then the system has been getting better and better because it's learning from the human curation and then saving the time so that they can see patient and also ultimately increase patient care. Another project is similarly called IDEKG. Is basically we use AI to automate the EKG document commit to Epic. This one doesn't even need human intervention because once we are able to find the patient of existing profile in Epic, we can automate the commit. So this has been deployed roughly about 3 months, already automated around 6,000 EKG files, so sending these critical files to the care in a timely manner. Yet another very interesting project we started and are working on is called FemScan, which is to find patients who are eligible for genetic testing covered by insurance. We developed an aging-based model that double the rate of identification so that allowing these patients to go through this critical screening for downstream treatment. We also build like a chat for the student because even though UTHealth Houston signed the first national agreement with OpenAI to get the API access in a HIPAA-compliant manner, it's $30 per person. We have more than 500 students in the school. So together with Dr. Susan Fenton, we use the open source platform WebUI or Llama build a platform, so allowing our students to experience generative AI without paying. And then this system is running inside our school with 2 GPU machines, 10 cards, so the student can experience and build their own GPT models. Yet another very interesting application, there's actually a poster. See if I can play the demo. The sound isn't coming out.
It's a benign tumor, but due to its location, we may need a rigid bronchoscopy to assess the extent.
Basado en la imagenología, sospecho un angiofibroma nasofaríngeo juvenil. Es un tumor benigno, pero debido a su ubicación, podríamos necesitar una broncoscopia rígida para evaluar la extensión.
So you're probably familiar with the commercial interface on the left, and then right is what we build. Why the commercial interface cannot recognize? Because it don't recognize those medical terms. Not only that, we can translate in a way patient could understand. So change the literacy level so that a grade 8 could understand. It doesn't change the meaning. It will change like a terminology like a glioblastoma into a brain tumor before we do the translation. And yet a very interesting application we built actually has been already created a lot of revenue generation is the AI-powered no-show prediction. This has been put into practice merely for 3-4 months, and then only about like 10 clinics are actively using it. We already see more than like 1,600 cases being rescheduled due to our prediction model. And then these schedules are filled with other patients who are waiting in the queue. So not only saving the time from the clinical room, but also allow the patient who are waiting to get a chance to see doctor sooner. With these systems, we also get into the patient orientation and onboarding. We build a pure agent-based system, allowing agent to talk to patient to check their onboarding status, and allow the agent to verify pre-operation conditions. So this system saves a lot of human operation time and accurately stay with the guardrail to extract information needed for the downstream. And not only that, we also bring this to the clinical care. We build 2D and 3D monitoring models to allow the tracking of stroke rehab patient to deliver the care. And we also build the AI agent for robotic platform with a vision action model. So you will see the robotic coming in the afternoon. This is the number 20 Aloha in the country. And all in together, we have a hub to synchronize all the tools we have. So with that said, I will leave this to the next phase. We're building additional platforms for space medicine, stroke rehab, and other applications. Thank you.
All right. Our next speaker is Yang Ji from UT Southwestern.
Hi, good morning, everyone. I'm Yang Xie. I'm a professor and the Associate Dean of Data Science at UT Southwest Medical Center. So today I will talk about the AI in precision health. So AI can identify different types of biomarkers for precision health, from early detection to diagnostic marker, prognostic marker, and the predictive markers to select the best, the right treatment for individuals, and also pharmacodynamic marker to select the right doses. So today, I will just use a few minutes to highlight a few examples that our team has been doing over the past decade about how did we use data science and AI for precision health. So the first example is to use genomic signature for treatment response prediction. So in this example, we combined machine learning together with genomic platform to identify a 12-gene set predicts survival benefit from adjuvant chemotherapy in non-small cell lung cancer patients. On this figure, we show that based on our assay, the predicted benefit group will have largely survival benefit for patients who receive adjuvant chemotherapy after resection compared to patients who did not receive chemotherapy. However, for the predicted non-benefit group, actually there's no survival benefit at all. So our finding has been validated in multiple cohorts across different countries. And right now, the clinical assay has been produced and is under clinical validation. So hopefully, this assay can be used in patients in the near future. The next example I want to highlight is how we use the AI together with digital pathology to improve diagnosis and prediction. So we developed the AI model. So the first thing is, this is from the routine diagnosis slides, pathology slide, H and E slides. From here, we use our deep learning method to identify individual cells and also classify cells into different cell types. So we call that HD staining, in contrast to chemical staining because this is, we just use our model to classify different cell types. From there, we can build a cell graph model based on the latest graph model. And then from there, based on the morphology of individual cells and the interactions among different cell types, we were able to do a lot of things. Here, for example, we can do the diagnosis, prediction, and so based on this, we can have a faster diagnosis, more accurate, and more cost-effective. So next, I will just show 3 examples of how we utilize this HD staining together with cell graph. So the first example is, again, this is a collaboration with MD Anderson. We use our model to predict the time to malignancy. So these are patients who did not have cancer yet, but based on their pathology slides, we can predict whether this patient is high risk to develop cancer or not. Based on this, we can see that actually the predicted high-risk group developed cancer much faster than the low-risk group. Actually, these give a way for a better preventive medicine for those high-risk patients. The second example is for the clinical diagnosis of subtyping. So here, again, using our method, we can achieve almost 98% of accuracy in terms of identify subtype of lung cancer. And the last example is using our model to predict benefit from targeted therapy, EGFR targeted therapy. And then again, we can show that our model, again, only based on the digital pathology, H&E slides, together with our model, we can predict who will benefit from targeted therapy. So our work has been applied to different types of cancer and have a lot of publications over the past 8 years. So the next example is how we can use AI for drug discovery. So this, again, just very quickly, this is an example that my colleague used AI-assisted design of T-cell receptor, TCRs, to be able to design the novel TCR so that can benefit for the cancer treatment, and also not only cancer, but also infectious diseases. And the next example is using AI to help antibacterial resistant tests, and this can be much faster and much more accurate compared to the traditional method. So, latest, actually, 2 years ago, after ChatGPT was just released, our first question is, can we use ChatGPT or large language model to help us to kind of extract information from clinical notes? So we were the first group to publish the paper, a very critical assessment of using ChatGPT to extract information, structured data from the clinical notes. And to our surprise, actually, the accuracy is really good, much better than the traditional NLP method. So this paper was published last year in NPG Digital Medicine. And this really opens a door for us using a large language model to utilize unstructured clinical notes for research and clinical care. Right now, we're developing a lot of multi-agent model to utilize. The last but not the least is, in order to do this AI modeling, we need to have a lot of data and put the data together. So because of that, about 10 years ago, we developed a platform called Data Commons to integrate data from different places, different types of data, research, genomic, and clinical data, and then build a user-friendly platform. And actually, we got funding from CPRIT to build this pediatric cancer data commons to really collaborate from our own children's hospital and many children's hospitals in Texas, together with the children's oncology group and also some other hospitals in other countries. So with that, thank you very much for your attention.
Thank you. Our last speaker is going to be Dr. Lawrence Court from MD Anderson. I may have time for one question when we're done, so if you have a burning one, be ready.
Thank you. Here they are. Okay. So good morning. So I'm going to talk to you about the Radiation Planning Assistant and how we're using AI to improve access to high-quality radiotherapy across the world. Just these first two pictures are us at two of our partner sites in Zambia and Indonesia, where we're just demonstrating the unit and showing how we can use it to do treatment plans for patients. Okay, so I have a couple of background slides just to give everyone understand the motivation behind this work. So if you live in Houston or Texas and you have cancer, you're very likely to have radiation therapy as part of your treatment. About 50% of cancer patients benefit from radiation therapy. And there's a lot of access, it's very good access in this part of the world. But if you go outside of North America or Western Europe, there's a very, very different situation. And that's what you can see in this map here, where the different colors are showing the percentage of cancer patients who would benefit from radiation therapy who actually have access. And if you can make out the colors, you can see that in many countries, less than 50% or even less than 25% of patients who would benefit from this treatment approach have access. It's not just access to radiation therapy, it's also access to high quality radiation therapy. You know, radiation therapy has changed a lot over the last few decades, but still in many countries, if you go and get treatment, you're being treated in the same way that we would have treated here in maybe the 90s or maybe even the 80s. So it's a very different treatment approach with higher radiation-related toxicities. So it's been estimated if we could close that gap, we could save close to 1 million lives per year. So that's my, that's the most compelling part of this slide, I think. We could make a big difference. And there's lots of reasons for this lack of access, as you can imagine. But one of them is just lack of people to do the job. So in order to create a radiation therapy treatment plan, you need the support of radiation oncologists who've been through graduate school and training and residency and what have you, and also medical physicists, which is what I am, and we have a similar training process where we have graduate school and residency. So we need a lot of these people that are difficult to train. Why do we need so many people? It's a complex process. So once you come in with cancer, we decide we're going to treat you, you then typically have some sort of imaging like CT scan, and then there's a whole process that has to happen in preparing the radiation treatment plan. So we have to identify the tumor, draw around what we want to treat. We have to also draw around, typically even in 2025, this is still done by hand in most centers. We draw around each individual structure that we can see, and you have to do this because each structure has a different response to the radiation, so we have to understand that. We then have to decide where the beams are going to come from, how we're going to treat, what level of intensity of radiation and things like that. And then finally, because radiation can do a lot of good, but it can also do harm if you do it incorrectly, there's a lot of quality assurance by physicians and by physicists and other staff to make sure that the treatments are correct. So this is a long process. In terms of actual hands-on time, it can be half a day easily of physicist and physician time. In terms of end-to-end, because of handoffs and what have you, it can easily take a week, potentially two. Luckily, most of these processes are prime candidates for AI now. And so we can actually do all of these, but in the first version of the Radiation Planning Assistant, we've just taken contouring, planning, and some of the quality assurance, put this into a web page, which we're now making available to clinics across the world. This is just one example. This is us in Tanzania, where the Ocean Road Cancer Institute, which is their primary radiotherapy center, they uploaded their own patients and performed 60 reviews of the contours and the plan. Nearly 100% were acceptable for use as is, and then potentially even more impactful than that was the whole process was 6 minutes, whereas if you do all this by hand, it's typically 1 to 2 hours per patient. So imagine that per patient. You're saving a lot of time per patient. In terms of scalability globally, we've done a lot of work internationally. So this is our biggest study where we had 31 radiation oncologists from 6 different countries review cases and score in terms of would they use the plans or not. And generally, we're at a sort of 80 to 90% use as is, with the rest requiring some sort of edits, which only take a few minutes compared to the several hours that it will take if they were doing everything from scratch by hand. This is our timeline. I just thought it's sort of interesting to see that this took a long time. So we started in 2015-16. with funding from the NIH in 2016. And then over time, we've worked through the regulatory process. We've been to the FDA. We've been through legal. You can imagine there's a lot of work involved in making sure we're not breaking any laws in South Africa and Zambia and what have you. We've treated our first patients. We've gone live in South Africa. We do use these tools at MD Anderson, which I didn't mention. We use them for about 300 to 400 patients a month. But the long-term goal is for these other countries. We're live in South Africa and now focusing on these other countries. So thank you very, very much for your time.